Much obliged. Thank you, Richard. And look, we've got Phil Harper. He is here. Phil Harper is in the room, which is fantastic news. So in that we had a little break at just after 2 o'clock, we thought we might just push on now, Phil, if you're all ready and set and good to go. We thought we might just bash forward, keep going. There's lots of people saying thank you to Richard. I don't know whether you've been on any of the rest of it, Phil. We've had an absolutely fantastic day so far. Lots of really impressive presentations from all sorts of very different people. We've even been up to the northwest coast of Scotland to the luxury Torridon Hotel, and some lessons in leadership from there. We've had Anne Marr on from St Helens and Knowsley first up. We've had David Loughton. We've had all sorts of people. But Phil, you're going to talk to us today about rethinking gender neutrality in health and social care. I should tell all of you who may not know him, Phil is a fantastic guy. He's a huge supporter of the Institute, and he's the senior lecturer in health and care management at Arden University. He's also co-founder of the LGBTQIA plus staff network at Arden, which I think is a fantastic initiative. Phil, if you don't mind, I'm going to hand straight on to you. Thank you very much.
Thank you so much, John, and thank you for inviting me to speak. Really looking forward to it. Yeah, thank you for that introduction. So I'm going to be looking at rethinking gender and reframing gender neutrality. I'm going to be focusing mostly on dementia care because that's where my research is in, but I will be also exploring some examples of how it can happen generally in dementia care. So yeah, my name is Phil Harper, I use they, them pronouns, and I am a senior lecturer in health and care management at Arden University. I mostly run our undergraduate apprenticeships for managers wanting to develop in health and social. So just a bit of an introduction here, and really this is a lot focused on dementia care, but we still have similar issues across health and social care, is that we don't really know full numbers very well. There's some report coming out now where we're starting to get a slightly better picture, but at the moment numbers are still very difficult, and it's quite often having to do a bit of mental gymnastics to try and get numbers. And we're starting a bit more about gay, lesbian and bisexual people. However, gender diverse or non-binary and transgender people living with dementia or accessing healthcare services is still quite a difficult area to know the numbers, partly because obviously people don't feel comfortable to post this information, and that's something that we will quite often go on to. I think it's really important just to give the information that I'm going to use gender non-conforming quite a lot within this, and it's an umbrella term for people who do not conform to gender norms and binary expression. And why I wanted to say that is because gender non-conforming is such an open term, and it's quite often adopted to mean so many different things. So really, I'm using it more of a gender diversity angle, and people who are, for example, non-binary, gender fluid, etc., and do not conform to the male and female binary. What I found with some early studies on trans and dementia, particularly, and this is the same within health and social care generally, is that it's very binary focused. Now, the trans umbrella does encompass non-binary and people who don't fit on the binary, in whichever way they identify as. However, quite often research is very trans and binary trans focused. And particularly within dementia care, I really do struggle to find anything that explores anything outside of the binary. It also, particularly something that I find with dementia care, is that it poses this question about whether somebody forgets their gender identity, and that's incorrect. And there's many different areas where it says that if people are vulnerable, people are accessing health and social care services, people might struggle with their gender identity. However, that's incorrect, as I said, because we quite often know our identity, and that's long before we actually express it. So it's actually the expression that people quite often forget, or people struggle with when they're a bit more vulnerable, because it's that ability to see your body, understand your body, particularly if somebody's had affirming surgery, but also it's just about expressing that. So we need to really change that discourse discourse or that way of thinking that actually it's not people's gender identity that people forget when they get dementia or go into health and social care, it's their expression. And by doing that, we're looking at it totally different. And early research does not commonly discuss gender neutrality and non. It might, if anything, erase it because some of the research talks fantastically about the right for people to self-identify and to support people. However, it is very much binary focus, and it's very much about when people change genders from one binary gender to another. And we need to think about actually what happens if somebody actually dismisses the binary, because there's more and more people who are identifying as non-binary, and we need to accept that in the world now. So there is some more research that's coming out that's starting to break down these gendered assumptions. So starting to break away from this binary thinking. So this is kind of an overview of some of this work. And it very much looks at dementia does degender individuals, and with an overemphasis on cognitive decline and ableist assumptions. So it's very much takes away somebody's autonomy or somebody's ability to present their own gender, because we assume that somebody is presenting in that way due to the dementia, particularly if somebody's in a nonconformist way. And we quite often see this in other areas such as learning disability or intellectual disabilities, and many other areas where quite often the over-pathologization of a condition or a way of being or who somebody is takes away somebody's ability to present in their authentic form. The heterosexual matrix often includes people who form their gender in a different way. So we very much have a way of looking at people in a very cisgendered heterosexual way. And we quite often then exclude people who don't fit in with that. And systems quite often do that as well. And we need to think about how that might happen. Normative discourse and how it impacts how a person performs their gender, especially with dementia. So we're thinking here how, again, building upon that first point, that quite often people with, if somebody's got dementia or has any other condition or way of being that impacts somebody's ability to maybe dress themselves, present them totally independently, actually how this might take away from somebody's gender presentation. But it's not always helped us, because actually dementia can help people, because if people are more willing to be open to different presentations because of somebody's dementia, it might actually allow somebody to actually be more non-conforming. So it's like a double-edged sword going here. Dementia can enable a person to perform their gender in a more authentic way, opposed to failing to present their gender due to feeling more freedom. So again, building upon that, sometimes dementia can get rid of some of those barriers. We can actually feel more free. People can actually feel more free to be their selves. Again, much of the work around gender and dementia is a binary focus. Again, the work that I've included at the top here have said this too. So it's not just me identifying this. It's very much we need a more non-conformist view, and we need to think about this a lot more different. And then some of the research touches on new ways of presenting gender through clothing and how this might disrupt the gender binary. So actually how somebody having a more eccentric way of dressing might actually mean that that person is non-conformist, and actually what might that mean for somebody's gender identity or gender expression, because sometimes gender expression, gender identity can be very different. So somebody might be very non-conformist but still have a binary gender, and vice versa. But could it still give indication of a different gender identity and a different way of supporting that individual, and not always viewing the person as somebody who's failing to dress themselves? So here we started to think about gender neutrality differently. And this is really what we need to start doing in health and social care, particularly dementia care. Start thinking about actually really allowing somebody to dress themselves, even if it doesn't fit in with a way that we see as being the norm. And what we need to start thinking about more is around intersectionality. So for those who maybe don't know what intersectionality is, it's really where two characteristics overlap really to create a unique experience. There's a fantastic quote here that I've included, and it's the concept of intersectionality describes the ways which systems of inequality based on gender, race, ethnicity, sexual orientation, gender identity, disability, class, and other forms of discrimination intersect to create unique dynamics and effects. So quite often what happens is if you have multiple forms of discrimination or multiple characteristics overlapping, you can become invisible because they kind of start cancelling each other out and making it quite complicated experience. And then people ignore, people also sometimes struggle to deal with, but also become invisible because if people say individually that they support each one of those things, but don't look at how they interact with each other, it actually makes that person invisible. This is what happens quite often within most trans and dementia studies, looking at the binary and being over medical. It's very much adopting a trans positive approach, but they're not thinking about how dementia might impact this, and vice versa. Thinking about how do we support people living with dementia, but also how might that be different or gender non-conforming or trans individuals. And this is what we need to think about. We need to start marrying these two needs together and thinking about how they impact on each other, not just looking at them independently. Some views can be that a person is not trans or gender non-conforming of this medical views of disability and cognition, like in learning disability and intellectual abilities. We need to have a more affirming intersectional approach. So again, we need to not just look at the condition or the way of being that somebody is and actually think about actually what else is going on. We need to be more holistic in our approach, and that is normally adopting an intersectional framework to do that. And the need for gender neutrality to be offered as an option, binary options. So the argument here is I'm not trying to suggest that we take away binary options because people identify within the binary, but it's about offering different options and rethinking gender neutrality that has always been seen as something that degenders people, but actually as a valid gender in itself. And we need this mixed approach, really. And that gender neutrality can be offered too, and it's not seen as just a symptom of dementia. So what I find really interesting, and it was suggested by one of my PhD supervisors to look into this theory, and it really does fit massively well into these concepts. And this is the idea of translocational positionality. And it's a really fancy word, but basically what it means is it means that we change based on our context and what's around us. When you think about particularly somebody living with dementia going into care culture, or anybody really going into health and social care setting, I am non-binary and I am an activist. I'm also a part-time drag queen. I'm very different when I'm out of work to a certain degree, but out of a setting like a healthcare setting. I am very loud. I am very passionate about my work when I am teaching, when I am doing my activism. However, if I became unwell and I went into a health and social care setting, I might change based on cultures, based on everything that's happening around me. I might be very open to being gendered, etc. Because it's partly picking that fight. And also, if you're unwell, you do change. But also the setting, you don't necessarily feel as safe and comfortable challenging because you're in a very heteronormative setting. So these are things that we need to start thinking about as well, and particularly in relation to gender diverse individuals and how people might change coming into such a heteronormative and cisgender normative setting. And for those who don't know, cisgender just means the opposite to transgender. People quite often think of it as a slur, but it is not. It's just a technical term to state that you identify as the sex you're assigned at birth. So when we think about all of this, we've got to think about socially constructed views of gender and expression, and thinking about how quite often these very binary approaches within health and social care settings might have an impact on people who are gender diverse. So again, here in queer spaces and cultures, an LGBTQ plus person might feel more comfortable expressing their gender, but maybe not so much in these heteronormative biological essentialism. So this idea that your sex assigned at birth dictates everything. And this very much fits into health and social care quite often. We still hear things like women's health units, etc. So it's really focusing on health needs based just on biology and not thinking about the wider implications and actually how gender and social construction has an impact on how we view our bodies. It's not taken away from the biological aspect. How we view the biology is influenced by social context, and we need to think about that a little bit more within health and social care. Emotional labour being in healthcare non-queer settings, so it's massively tiring, it is scary, it's intimidating. Healthcare settings are like that for everybody. But imagine also if you don't feel comfortable or you don't feel safe being yourself in that setting, how that compounds and it builds. And then dementia and other conditions like that will just make it even as scarier because you've got a whole nother layer of vulnerability and fear. And we can't really ignore the political climate for trans and non-binary people at the moment. Incredibly hostile. We have the Equalities Minister at the moment who is actively transphobic. So things are moving. There's a lot of talk about gender reassignment being rethought about in the Equality Act to take a lot of protections out. So it's quite a scary time at the moment, and we've got to be aware that that will impact health and social care, particularly because a lot of the guidance that comes from the Equalities Commission is actually transphobic and breaks the Equality Act, and they talk a lot about healthcare, and actually a lot of the guidance recently has actually broken the Equality Act. So again, it's quite a toxic culture, and we've got to think about that, and also think about the fear that people might have outside and then going into health and social care is also exacerbated. And then a thinking point really, when I was thinking about all of this stuff, is that actually there's quite a lot of people who state, again, like what I've said, that gender neutrality quite often erases dementia. But at the same time, we're looking for this being an alternative. So we're not trying to talk about gender neutrality replacing everything. It's just about it being an option, which currently doesn't really exist. So it's just a thinking point, really, to think about. Gendered literature is fantastic, but at the same time, we need to offer gender neutrality with the gendered literature. Just a key point there. And then building back on that idea of the fear in certain settings, and it's if an environment, for example, isn't very accepting, we quite often internalize a lot of upset. And the Foucault's panopticon is a really good analogy for this. So the panopticon is a circular prison, as you can see on the screen, and you've got a central watcher or central group of watchers sometimes, but you have this central watcher in the middle. And because anybody can be watched at any one time, it becomes an incredibly efficient way of monitoring behavior. Because even when you're not being watched, because you can be watched, you still self-regulate, you self-monitor yourself. And when we think about this within settings, and we think about heteronormativity and cisgendered normativity in settings, being that central watcher promoting this way of being, even when people should be free to be their authentic selves, they might internalize and self-regulate and hide themselves, go back in the closet. This is why it's so massively important to think about environments and to think about what we do in care culture-wise to change that central watcher to be affirming of all and not just non-binary, gender non-conforming, gender neutrality, but everyone, other LGBT folk, even people within who don't identify with the LGBT community, have a different way of dressing, for example. It's really about just trying to support everyone and trying to be far more person-centered. and trying to stop people from internalizing upset and damaging themselves within. And that is what this is really trying to think about, this concept. And then finally, just some points for practice before I open up to any questions. I want to make sure there's plenty of time for questions. And really is that we just need to think about gender neutrality as a valid gender. So we are not thinking about it as a failure to present gender due to cognitive decline or any other conditions. Think about environment and the importance for a positive care culture. Again, challenge those heteronormative assumptions, but sometimes also it's physical cultures as well. I know we quite often talk a lot about having LGBTQ plus insignia, lanyards, posters, and that's incredibly important because it makes people feel seen, etc. But also work towards gender plurality, this idea that actually binary genders and gender neutral genders can both exist at the same time. So it's about not replacing binary genders and gendered identities, but it's about really highlighting that gender neutrality does exist too, and it is not just a negative. It can be a positive. People like myself who use they, them pronouns, I still exist. I'm not they, them because I've got a condition, for example. And I think this is a quote from somebody who might even be here right now. But this is a quote that really, really hits home for me and really had massive, profound impact. And I got permission to be able to use this in my presentations. And it's, oh my God, I'm terrified. Not about dementia and the disease progress, kind of like the idea of babbling away into oblivion. What I'm most afraid of is having heteronormative care imposed on me and having my queer identity erased. When I hear we treat everybody the same, what I believe they're saying is, yes, we treat everybody like cisgender white folks, not my lived experience. And I think this is such an important quote to say that we are not all the same. We need person-centered care, and people who are not cisgender, who are not on the binary, also do need support. And I think we need to highlight and raise that we do exist in health and when we access health and social care, we need to still exist. And this is what it is about, not having that queer identity raised, which currently health and social care, particularly for non-binary and gender identity folk, gender diverse folk, does happen. And that's my references. So thank you. As I said, I wanted to make sure I had plenty of time for any questions, because I know I'll probably raise a lot. And at this point, I haven't got as many answers. It's more about having this discussion and trying to raise awareness. So thank you.
Well, thank you very much indeed, Phil. I think that's a fascinating insight, and I've learned a huge amount this afternoon. I will confess, I just find it really difficult to use the correct pronouns for people, not because I don't want to, but either I forget or I become confused in my speech about what I'm trying to say. And it's something that requires practice, I think. And if you agree to practice, then what you're saying is you're opening your mind to the fact that this is an important thing that you choose to try to tackle. And I think that's a really important message that I've received this afternoon. So thank you, Phil. All right, would anybody like to ask Phil any questions at all? I'm sure they'd be very pleased to receive them. Dorothy, yes, please.
Hey, Phil, and thank you, as always, for a fabulous presentation and for quoting me so nicely. That was my quote. Thank you. Is there any safe place for gender non-conforming people with dementia in the UK that you're aware of?
So it's a very difficult one, because it's all dependent on the organisation. Now, I know we've had really long discussions around the importance of possibly having queer-only care settings, and that's never an end goal, because the end goal is for integration, but we're not in a safe space for integration at the moment. And I think the important is with that think about that heteronormativity and how we internalize stuff. Most care settings are so heteronormative that actually we kind of do need queer-centered care provision. But hopefully in the future, when things become far more integrated, we can integrate better and things improve and we drive forward. Now, that hasn't really answered your question. That's just my pre-bit to it. We do have some LGBT specific services. So you've got Tonic London. I know that is very expensive. And I know, again, we've discussed about that, Dahi. But that's incredibly expensive. But they are very good with gender diversity. And there are some developments happening in Manchester, I believe, with a lot of extra care settings becoming LGBT centric. So my hope would be that they would be very aware of trans and non-binary identities and have really good gender affirming care. I think these discussions are very early on. As I said, sadly, I'm one of the only people I know really going into a lot of depth into this. Now, there's plenty of people who are exploring this, but I always find it's very binary focused. So looking at the gender neutrality, the non-binary aspect, it's very much drips of work. There's not much, but my hope is that through raising these questions and trying to open people's minds to this, things will improve. So at the moment, it's looking at what LGBT centric support is happening. And said Manchester, I know there's a little bit in London, and particularly through Opening Doors, they're doing a little bit. And I'm just hoping that more will happen. And as you know, there's a few of us going on about this. So hopefully we'll raise the awareness and really open people's eyes up to it. And I think it's important to remember that it's a lot of this is based on lived experience, and it's not people's fault if people aren't aware about the need of this, because we base everything we do on our own lived experience quite a lot, and it's quite a unique lived experience, I'd say, and it does challenge a lot of thinking that we've been brought up with. So I appreciate the difficulty with it, but hopefully these messages will get through and people will start to open their eyes to a different way of providing care.
Thank you. Thanks.
Phil, any other questions? Can I just mention, Phil, that John Mathias has put in the chat, which I think I thought it was a massive point that you raised. This, we treat everyone the same. That they're expressing that as a strength of their service provision. I mean, I find that I'm not. I think I'm more like a red flag if I see something of that nature, because there are so many idiosyncrasies around every one of us that why would we want to be all treated the same? I think it's a dangerous psyche to get ourselves into. Lindsay.
I know I have this discussion a lot with people, and I was at UK Dementia Congress the last couple of days, and I was helping to support an EDI roundtable discussion because I'm part of their EDI committee, and we were discussing a lot of this and about the importance of person-centered care, and person-centered care should encompass EDI, and EDI should encompass person-centered care. You can't split them apart, because EDI, in its broadest sense, like equality, diversity, and inclusion, but should be equity, really is all about treating individuals as individuals, understanding and respecting difference, because we are different, and don't erase difference. Like, my frustration is when people say, oh, I don't see colour, or I don't see sexuality. I'm like, well, we want you to see it, because if you don't see it, you can't treat us right. Don't over focus on it and don't boil us down to it, but you need to see it. And I think that is the important thing. And I think the difference should be, and I always get people to rephrase it, is that we respect everybody the same, not see everybody the same. And just that one word change totally changes the message for me.
I like that. That's a great takeaway for all of us today. We respect everybody the same rather than necessarily we treat everybody the same. That's a great one. All right, that's going in my editorial in a couple of weeks' time, I promise. Phil, as ever, hugely grateful to you. I think you're an admirable person, and I love the fact that you present with such vigor and passion and determination, and long may it continue. So let's hear it for Phil, please, everybody.
Thank you, everyone.
Do that as well. How about that? There we go. All right. Thanks a million, Phil. Lovely to see you. And isn't that interesting? You know, I hope everybody's taken away some points from that they can then put into their daily working lives, all for the better. I think, you know, we can all learn from all sorts of different things here. Paul says the other phrase that he finds challenging is treating people as you wish to be treated. I think this is just a slightly milder version of the same thing. I'll take that, Paul. Perhaps treat everybody how they want to be treated would be better. And how do you know? Ask them. That's a nice way to put that. And Phil's just put their email address up there as well. So if you'd like to contact them directly, then they will answer that, I'm quite sure. Thank you. You see, I'm learning already. There we are.